Okay, we're going to go ahead and get started now and let folks trickle in as they are able. But I wanted to first introduce myself and everybody to the PGSSC Research Seminar Speaker Series. My name is Sarah Ness. I'm going to be moderating the session today, and it's an incredible privilege to be here welcoming two really fantastic speakers who will be discussing their work related to global surgery readiness assessments and surgical capacity building. Our first presenter today will be Dr. Albino Kalolo, who is going to be presenting on the development of upgrading public primary healthcare facilities with essential surgical services infrastructure in Tanzania. And our second presenter today is going to be Dr. Katie Iverson, who will be discussing the development of a surgical assessment tool for national policy monitoring and evaluation in Ethiopia. So it is a great privilege to have you both here today. We're really looking forward to your talks. Briefly, we'll just give a background to the PGSSC Research Seminar series. So this is a 8-session series that we have been conducting over the past 2 years. We currently have two more sessions remaining, so please tune into those in April and May. Each session features 2 speakers that discuss topics or methodology, a given research theme, followed by 30 minutes of open discussion on the results and methodology. We will post a video of the research seminar recording after this event on our website. And this is a brief introduction to our team. As you can see here, we have 2 fantastic faculty leads, Dr. Boten and Dr. Gauthier, and a variety of PGSSC fellows and research collaborators who've been involved in organizing this series, as you can see here. So to introduce our first speaker, Dr. Kalolo. Dr. Kalolo is a senior lecturer in public health at St. Francis University College of Health and Allied Sciences, where he also serves as the current dean of the Faculty of Medicine. Dr. Kalolo completed his medical training at the University of Dar es Salaam, followed by a master's in public health from Maastricht University in the Netherlands. He then completed his PhD in public health from the University of Heidelberg in Germany. His research areas include epidemiology of infectious and non-infectious disease, implementation science, primary health care, clinical decision-making, and policymaking. He is a co-founder for the Center of Reforms, Innovation, Health Policies, and Implementation Research, which is a think tank organization that aims to bring scientific evidence close to policy and practice. Dr. Kalolo is also a Global Health Equity Fellow through a partnership between the Health for Prosperous Nation and University of California, Berkeley, during which he spent a year working on his postdoctorate fellow research. We are really thrilled to have him here today presenting on his paper title, as you can see here. And with that, I will turn it over to Dr. Kalolo. I'll give you the screen share. Thank you so much, Dr. Kalolo.
Yes, can you see my screen? Hello?
Yes, I can see your screen.
Oh, okay, good. Yeah, so my name is Albino Kalolo. As I've already been introduced, I'm from St. Francis University College in Ifakara here in Tanzania, and I'm a senior lecturer at the Department of Public Health. So I'll be presenting a paper that we published 2 years ago together with my colleagues. You can see the list. And the paper was on development and upgrading of public primary health facilities with essential surgical service infrastructure. And we consider this as a strategy towards achieving universal health coverage in Tanzania. Yeah, so in a nutshell, we can say achieving universal health coverage is one of the targets of the Sustainable Development Goals. And Sustainable Development Goal number 3, which actually focuses on universal health coverage, where we actually want all people should have access to quality health services when in need without facing any financial hardship. Yeah, so this is an important goal that is supposed to be made by all countries. And infrastructure development and upgrading, which is a supply side activity, is actually very essential component of the quality of healthcare. The condition of physical infrastructure of health facilities, availability of equipment, and supplies, medical supplies, but also ICT infrastructure are important dimension of structural quality. Yeah, so structural quality of services will actually depend on infrastructure and all these other components. In Tanzania, where there is a rapid population growth at 3%, but also the fertility rate, which is also high, 4.8, requires an infrastructure development, which is goes proportional with the population growth. And to make sure that we have infrastructure which can actually cater for structural quality for maternal health services, especially the comprehensive emergency obstetric care at the primary health care, yeah, we actually need to see how we can improve this. And this has been done in Tanzania, where there has been a massive improvement and upgrading of the CMOC facility, so that at the end of the day, the population can get the required services. The primary health care in Tanzania, which is implemented in a decentralized district health system, is actually an entry point to the healthcare system, and actually requires to be more strengthened so that people can enjoy services at this level. To make sure that people can access quality services, there has been several reforms in the country. And notably, we had wider reforms in 1994, the health sector reforms, which were big other reforms. It means most of the components of the health system were reformed, from financing, human resource, and medicines, and other components were reformed so that more services could be accessible at the primary healthcare services. I mean, at the primary healthcare level. And this was also followed by formulation of the medical store department, and recently the prime vendor system, where this prime vendor system competes, supplements the medical store department when it comes to making sure that health commodities are available at the primary healthcare level. But there has also been health financing reforms, like the direct health facility financing, but also implementation of the improved community health fund. All these reforms are aiming at making sure that there are enough financial resources at the primary health care so that services can be offered. Sorry. Okay, so among the reforms, there is this big reform which happened from 2007 to 2017, which was infrastructure development program for primary health care. And this aimed at developing infrastructure at the primary health care level, but also making sure all other important inputs like the human resource for health, equipment, and medicines are available at the primary health care, but also strengthening the referral system. And this was extended for 2 years between 2017 and 2019. Then later on, there was development of the Tanzania First National Surgical Obstetric and Anesthesia Plan, which was jointly implemented by the government of Tanzania with the support from the Harvard Medical School. Yeah, so these are some of the important reforms in the primary health care, which actually led to the development of preparing the primary health care to practice safe surgery so that the people can get good services. But over time, there has been several systems to monitor progress. And there are facility-based approaches and population-based approaches. When it comes to facility-based approaches, we have the star rating tools. Every year, the facilities are assessed to see the quality of service provision. But in this star rating tool, there is assessment of the process quality, but also the structural quality, which is actually the focus of our presentation. But also there is Tanzania Service Provision Assessment, where periodically there is an assessment to just see the type of services that are being provided and the quality, but also access, availability, and all those dimensions. But also there is service availability and readiness assessment tool. Yeah, so all these facility-based tools, they are there to monitor the progress of the improvement of the primary health care. But also there are population-based approaches like the demographic health surveys, which are conducted periodically, most of the time after 5 years. Then there is a comprehensive demographic health survey where we actually get, several indicators assessed when it comes to quality and access to services. Now, in relation to this study that we conducted 2 years ago, the broad objective was to describe the implementation of innovative infrastructure improvement program for public primary health facilities. And we wanted to know what happened since 2005 to 2019. Yeah, so that was the broader objective, just to get a wider picture of what is actually happening. The specific objective was to understand the public sector efforts to improve the infrastructure of primary health facilities between 2005 to 2019. But also we wanted to assess the construction rates within this period, but also the geographical coverage and physical status of the facility, safe surgery situation, and service rendered in public health facilities. Yes, this was our second specific objective, as we aim to see what is the situation as we move to universal health coverage. Yeah, so primary health care is a part of the national care system where the majority of the population access services. The primary health care services are provided at the disposal of the health center, the dispensary, level, where it's at the level services provided at household, community care workers, outreach centers.
Sorry, Albino, are you there?
Hi, Dr. Kalolo. I think your audio has gone out for the presentation. I don't know if you can move closer to the microphone or switch microphones.
For Hello, can you hear me?
Yes, we can hear you now.
Okay, did you hear the primary healthcare arrangement in Tanzania? The slide that just I have.
No, we did not hear that portion. So maybe if you could do a brief recap of that slide. Thank you.
Okay, yeah, so the health services in Tanzania are organized like in a pyramid shape, where at the base you have community health services. And then you have the dispensaries, which is present in most of the villages. So at the village level, you have a dispensary. And then you have a health center. A health center, it's a referral for the dispensaries. 2 or 3 dispensaries can refer patients to the health center, which is somehow more advanced, and that is where you can even get some basic surgical services, especially the CMOC services that I have just been mentioning can be availed at the health center level. And there, then you have a district hospital. That is a referral for all health facilities at, at the primary healthcare level. Yeah, so the primary healthcare level has these 4 structures: the community, dispensary, health center, and the district hospital. So that is what I just wanted to explain in the previous slide, but unfortunately, probably you could not hear well. Yeah, so that was that is a context in Tanzania when it comes to primary healthcare. So even when we talk of infrastructure development, upgrading, we talk at that level. Yeah, now the study design was a cross-section analysis of countrywide routine data on health facility infrastructure assessments and various reports from the assessment tools that I just mentioned before. I mean, from the star rating tool, the SALA, and other data collection tools which produces several reports. So we analyzed all these reports. But before going to the analysis of these reports, we had to complete some activities. First, we wanted to understand the theory of change of the infrastructure development program. That if you develop infrastructure, at the end of the day, what happens in terms of the quality of services and other important things for access to care. Then we want to understand the methods adopted in improving the health facilities, the construction and innovation, renovations. How does this happen? We wanted to know that, so that when we correct data, everything is clear. But we also want to understand the related reforms at various levels to support the program, the infrastructure development program. What other reforms are there so that this program can be implemented smoothly across the country? Then we described the data collection procedures and tools, and then we conducted the analysis. So in details, you can see activity 1 which was development and validation of the theory of change for the extension of the primary health care development program. We see that we mapped the activities that were supposed to happen. First is disbursement of funds from the government and non-state actors to the local government and the primary health care facilities, but also availing various guidelines and circular and drawings to the local government on the renovation and construction, formation of 3 construction committees, but supportive supervision and mentorship. Now you see these activities could lead to reduction in maternal morbidity and mortalities, increased use of surgical services, improved the referral system, and improved the infrastructure. Yeah, so we had to know this theory of change. And the second activity was to understand the methods of construction and renovations. Especially, we noted that there is a use of false accounts for renovation and construction, which had a great success. where district councils were able to procure building materials and or engage temporary labor to carry out the work without probably going through the bureaucratic tendering process. Yeah, so this was like a simplified way of tendering so that buildings can be built on time. But also understanding the related reforms at various levels to support the program. The various organization efforts at the local government level, financing the construction and renovation project, the direct health facility financing program on renovation and the maintenance of infrastructure, where funds from the Ministry of Finance are just sent directly to the facility and not through the council level or the regional level. Yeah, so this could facilitate renovation, but also sustainability plan of renovation and infrastructure development. Activity 3 was data collection procedure and tools, where we used the health facility registry, where all facilities are listed, and just to know how many facilities are there, which ones are new, things like that. But also plans and implementation reports at different levels of the health care system. So we reviewed plans and the implementation reports. But also infrastructure assessment checklist, a 7-item checklist, which assessed the physical infrastructure, latrines, as well as adequate functional rooms and buildings, infection prevention, waste disposal and facilities, and inventories for ambulances. Yeah, so we used this checklist. But also we had a CMOC, signal function checklist, which assessed the CMOC 9 specific signal function for CMOC designated facilities. So this is how we collected data for this study. And activity 5 was conducting analysis of the gathered data, where first we had to measure the variables which are important for this study. The health facility status variables, where we want to know the type of health facility, distance of the health facility from the district headquarters, years of operation of the facility, training status of maternal and safe surgery, physical status of the facility categorized into A to F, where A is good and F is too bad, location of the health facility measured as urban or rural. But also we had CMOC service data measured in relation to presence or absence of CMOC services. Another important variables, amenities in the health facility, the physical utilities and waste management equipment. The amenities studied including whether there is water, electricity, phone, incinerator, placenta pit, and waste bin. So those are where the amenities assessed. And we use the descriptive statistics and the inferential statistics just to map what is actually happening. Yeah, so the results, first was status of the facilities. A total of primary health facilities, 5,072, where we had more dispensaries compared to health centers were constructed cumulative by December 2016. So countrywide, more than 5,000 facilities. Of these health facilities, 90 were constructed in rural settings and 10% were constructed in urban settings. So the focus was rural because that is where majority of the people are, and that is where most of the mortalities and the morbidities are located. So there has been an average annual increase in the number of health centers constructed as compared to the dispensaries. For the new constructions, we are focusing much on health centers because that is where surgeries can take place, the basic surgeries compared to the dispensaries. Yeah, so here you can see that from 2005, there has been an increase in dispensaries, but also health centers. Even though, I mean, between 2015 to 29, you see that more health centers have been constructed. So majority of primary healthcare facilities had a physical status of a good state, while 33 had a physical status of B, which require minor innovation, and the remaining facilities had a physical status of C up to F, which is actually requiring major renovation or sometimes not to be used at all. And the majority of primary health facilities have been operating for more than 10 years. That is what we noted in the assessment. When it comes to comprehensive emergency obstetric care, of all health centers, only 115, which is 22%, were offering comprehensive emergency obstetric care. So you see that majority of the health centers at this time were not offering emergency obstetric care, especially the surgical services. It was found that out of 115 health facilities, only 20, which is 17%, were offering the CMOC with all 9 signal functions. Now, when it comes to all signal functions, you find that only 17% were offering such services. So in relation to amenities, in this study, only 17.4 of 115 health centers had facilities for offering blood transfusion services, and 33% of health facilities had a piped water, and 5.1 had a landline telecommunication system. The trend of construction and innovation has shown a sharp increase in the construction of building between 2017 to 2018. Yeah, during the extension period of the primary healthcare development program, we find that there was sharp increase when it comes to construction of buildings. A review of reports submitted from regions and district council indicated that out of that, there were 1,845 unfinished primary health facility buildings across the country, and they were at different levels of construction. Yeah, so there were also some unfinished the buildings. In the Kai Square, we found that facility location was significantly associated with the receipt of more training on basic surgical services, as those who were working in the rural public primary facilities received more training than the rural ones, than the urban ones. We also found that distance to the public primary health facilities to be significantly associated with the location of the facilities, as the people who resides in the urban have access to their facilities within 5 kilometers, as opposed to those who are in the rural area. So the facilities in urban areas are more closer if you compare to rural areas where they people can walk 5, even 10 kilometers to reach the facility. So as a point of discussion, we find that majority of health facilities were offering suboptimal quality of healthcare services, as their amenities were not up to the standards. That is what we noted. The finding that only 33% of health facilities had running water indicates that hygiene and sanitation is still challenged in most of the healthcare facilities, hence making the provision of quality of health services in the healthcare facilities a question. So water and sanitation is still a problem. In this study, we found that only 5.1 had a telecommunication system. This impairs the ability to implement referral systems between health facilities and providers. The use of force account during construction as an approach for construction and renovation of primary healthcare facilities has resulted in the saving of money, as there was a construction of more than 5 health facility buildings instead of 2 buildings that would have been constructed under a traditional contracting approach or procurement approach. There is a need to have adequate investment in the urban infrastructure, at the same time having strong public-private partnership framework that will help the people who are residing in urban areas to have subsidized the cost for the healthcare. We had noted that the investment in urban areas was low if you compared it to the rural areas. So methodological consideration of this paper, that the strengths was that we analyzed the countrywide data and this data actualize the foundation for further studies and evaluation on the subject in question. Yeah, so that was the strength of this study. But this study had some limitation that the data collection relied mainly on submitted reports from the available tools for data collection. And we could not do any interviews to actually verify some of the findings that we have observed. This study mainly focused on amenities, although and less on the outcomes of the patient. So we didn't go much to patient outcomes, whether this infrastructure development and everything that we see has resulted to better outcomes on the patient side. And the checklist that was used for assessment is mainly limited to few areas in the basic amenities to health centers and dispensaries, and efforts offers little to the district hospitals. So the focus was much on the health center and the dispensaries, but when it comes to the district hospital, we didn't assess most of the things. Yeah, so thank you very much for listening. Asante sana in Kiswahili. And if you want to read more about this paper, I have here is a link where you can read. Yeah, so thank you.
Thank you so much, Dr. Kalolo, for such a fantastic presentation and really commendable work. Very much looking forward to the discussion that we will have after Dr. Iverson's presentation. We're going to go ahead and switch over to Dr. Iverson. So I'm going to ask to unscreen share. Thank you. And while we're switching over, if everybody who has joined the call and hasn't yet filled out the Menti poll could please fill out the poll that was just posted in the chat so that we know where you're calling from today. Okay, I'm going to just. Okay, and with that, I'd like to introduce our second speaker today. So Dr. Katie Iverson is an assistant professor of surgery in the Division of Trauma and Acute Care Surgery at the Medical College of Wisconsin. She was a previous research fellow at the Harvard Program in Global Surgery and Social Change. So we're excited to see her back here today. From 2016 to 2018, during which she worked on surgical system development in Ethiopia and surgical quality improvement in Peru. Her research interests include trauma and surgical system development in low resource settings and violence prevention. She currently has active research projects in surgical indicator collection and trauma education in Ethiopia and trauma registry implementation and surgical communication in Cuba. We're really excited to welcome her back today. And Dr. Iverson, I will turn it over to you.
Okay, great. Thank you for having me. And thank you, Dr. Kalolo, for your presentation. It was really great and to hear about the neighboring country of Tanzania near Ethiopia and how things have developed there. Very excited, as Sarah said, to be back, as I was a previous research fellow at PGSSC. And so excited to share some of the work that I did while as a fellow there. Okay. That should be working well. Okay, so I'm going to talk about the paper that this was assigned for development of a surgical assessment tool for national policy monitoring and evaluation in Ethiopia. Maybe, let's see. There we go. So financial disclosures. So usually I don't have financial disclosures, but this study was actually funded by the GE Foundation. So it gets a little bit into the funding question, which was a grant that was part of a whole collaborative Safe Surgery 2020 that's focus was building surgical infrastructure in a few different countries. So Ethiopia, Tanzania, and Cambodia were those countries. For my talk today, so I'm going to give a little bit of background on Ethiopia and the study. I'm going to talk a lot about the study team because there was quite a few people involved in this collaborative. I'll give you an overview of the specific research question, some of the methods, and then results, and then talk about more lessons learned, hoping to leave a lot of sorry, I forgot to start my timer. Okay, to leave a lot of opportunity for questions at the end. So in this group, I don't know that I have to give a big introduction to Ethiopia since you guys are all globally minded people, but just a little reference of where Ethiopia is in Eastern Africa, near the Horn of Africa. It's the second most populous country in Africa, so the population is 120 million. And then just some kind of quick stats there for you. So most recent surgical volume, kind of looking at Lancet indicators, and this is from data from 2011, so not recently reported data, is 43 per 100,000 population, and SAO density is 1 per 100,000 population. So going back to the team for this study, so Safe Surgery 2020 and the GE Foundation's sponsored a lot of people to be involved in this collaborative. So first and foremost is the Federal Ministry of Health of Ethiopia. So in 2015, they created the SALTS team. So I'll say SALTS a lot. And what that stands for is Saving Lives Through Safe Surgery. And this was essentially the NSOP, or the National Surgical Policy for Ethiopia, that started in 2015. The goal of that, of course, was to evaluate what the current state of surgery was in the country, and then to be able to develop that further. This shows those 8 different domains of the Saving Lives Through Safe Surgery policy. So 1, leadership, management and governance, and then heading all the way to 8, which is monitoring and evaluation. And that's mostly what we'll talk about today. The different partners involved in SALTS, and this is at the inception, and of course more people were involved as it went along. But you can see the Safe Surgery 2020 collaboratives there. So those are all the groups that were involved with this project. Some of the academic institutions, some of the professional organizations, and then some other partners that were part of Safe Surgery 2020 and part of the implementing strategy. Of course, I want to thank all of my co-authors too, especially Olivia Ahern. She was co-author with me, co-first author with me for this paper. And of course, we couldn't have done any of this without that full team. So looking further, so I just wanted to give a little bit more background to, I think a lot of you are kind of familiar with Safe Surgery 2020 in this group, but that's more of a fun picture when we were doing some of the training for the monitoring and evaluation strategy in Ethiopia. That's in Bahir Dar at the lake there. So in Safe Surgery 2020, the grant came from GE Foundation, and then there were a few different partners that were part of this implementation strategy. So Dahlberg is more of like a governing management strategy, Assist International as one of the NGO partners, JPIGO, which has a really great record of implementation in Ethiopia, was also one of the NGO partners on the ground. G4 Alliance was helpful with coordination of a lot of the activities. And then of course the PGSSC in terms of the monitoring and evaluation study. So getting back to this study of topic, I'll give a little bit more of an overview of the study. So like I talked about, the Saving Lives Through Safe Surgery SALTS national policy. So these are the 8 different domains that were outlined in the policy, and every domain had specific implementation partners to kind of partner with to help advance these different avenues of a surgical system. So we, as the PGSSC, part of this was really involved in the monitoring and evaluation strategy. And so in collaboration with all of those partners and with the Federal Ministry of Health, we worked to develop 2 different strategies for long-term monitoring and evaluation of the surgical system. So the first part of that was the hospital assessment tool, which we'll talk about more as we describe the process of that development in this study. And then the second arm of that monitoring and evaluation strategy is the key performance indicators, which I'll just briefly mention. So first, so this is more of the topic of conversation today, is this hospital assessment tool. So there you can see kind of the front page of this hospital assessment tool for Ethiopia. And all of these resources, I should say, also are on the PGSSC website if you look at the Ethiopia part of that. So this is tool for situation analysis to assess emergency and essential surgical care in Ethiopia. There were 8 different domains that we assessed through this assessment tool, and pretty lengthy 363 questions to really form a comprehensive view of what's going on at each facility. The intention as part of the monitoring and evaluation aim of the surgical policy of the nation was that this hospital assessment tool would be done on a rolling kind of every 2 to 5 years for each facility in the country that provides surgery. And then briefly, just to mention, the other arm of the monitoring and evaluation strategy is the SALT's key performance indicators. So in contrast to the hospital assessment tool, which is meant to be assessed on more of a yearly or 2 to 5 year basis, these are indicators that are collected monthly at the hospital level. So again, there was a collaboration of key stakeholders in the country to decide on which of these indicators should be integrated into the monitoring and evaluation system. So these are indicators that are intended to be collected and reported on a monthly basis. There are some of these that are overlap with the Lancet indicators. So part of the PGSSC role is to make sure there were some internationally relevant indicators so that we can kind of track progress in Ethiopia going forward with other international groups. And then there's some that were more specific to the Ethiopia context that people wanted to make sure that we were able to evaluate. So for instance, the blood and availability ratio and also the anesthetic adverse outcome. So for this study, the aim was to describe the process of adapting the WHO's situational assessment tool into the resultant Ethiopian SALTS tool, and then present findings from its implementation for its initial pilot study. So I'll go into the methods a little bit here. So there's initially the WHO situational assessment tool. Say that 3 times fast. And then this eventually in 2015 kind of started getting developed, especially have to give credit to Yi Henlin, who really spearheaded this effort to kind of update that tool for surgical assessment on an international level. So this WHO PGSSC tool was then being created and kind of going through final approvals when we were working again on the Ethiopian SALTS tool. And so the goal was to bring in all of these different kind of assessment methods and to bring in the Ethiopian context specifically to create something that would be that would represent Ethiopian surgical system well. So for IRB approvals, just to kind of mention this briefly as well. So we had approval through Harvard, and then the Ethiopian Public Health Institute acted as our IRB approval for in-country approval. And this allowed us to survey multiple facilities throughout many different regions as opposed to being associated with a single hospital in Ethiopia. So that worked as a national IRB. And then there's a lot of approvals you have to get, as a lot of you probably know. So approval letters and support from the Ethiopian Ministry of Health, as well as the regional health bureaus that you're working in. So to talk a little bit about the tool development. So this was an iterative process with key stakeholders in the region. So a lot of this work came from the SALTS technical working group, which involved key surgical leaders in the field from Ethiopia. So the Ethiopian Surgical Society, Society of Anesthesiologists, and then, like we said, as part of Safe Surgery 2020, some of the main NGOs working in the region. The goal was to adapt that WHO PGSSC tool to make sure there were international standards within it for Ethiopia, but then also to make some more context-specific changes. This gives a brief timeline of how this went. So the SALTS policy development and that NSOAP was really created in 2015. There was a baseline assessment done in 2016 with the original WHO surgical assessment tool. And then from that, we started adapting this, realizing that there were some gaps in terms of what we were able to assess with that tool. We started to adapt this to Ethiopia. In 2017, we started with piloting this new tool in 14 facilities in the southern region of Ethiopia. And then from there expanded and then did some data analysis of this to look at what does this look like in terms of a country assessment for Ethiopia. But then the second part of the study was to look at what does this look like for international comparable metrics. So that showcases the region that we went to in the southern part of Ethiopia there. So there were 14 hospitals we went to. Most of them were primary hospitals, but then there was one general and 2 specialized hospitals as well. The way that we adapted the tool also was to break it into sections to give to different providers so that we could concurrently interview different people at the facility. So for instance, the hospital CEO, the surgeon, the anesthesiologist, and one of the nurses could all be interviewed at the same time if there was enough staff because of the way the tool was broken up. And then verification of this was with hospital walkthrough and also looking at operative logbooks. And then this was in 2017. So all of those people were involved in making this happen. So again, all of our Safe Surgery 2020 partners, as well as the government of Ethiopia. So to talk about some of the results. So I know this is, I think since we're all on Zoom, maybe it's easier to see. So I'm not as worried, I guess, about how small this writing is, but hopefully you can see this okay. I just wanted to show you some of the comparison between these tools. So the original WHO surgical assessment tool has those 4 different domains, has about 100 questions, and breaks up the healthcare facilities a certain way. Then looking at going forward to the WHO PGSSC tool. So that then has 5 different domains. There's more facility levels and then facility types. And then for Ethiopia, the domains still, we went to 7 different domains. It should be 8 different domains. I think one of those came off. And then the level of healthcare facilities, we could really make that specific for Ethiopia too. So the primary general specialized hospital are their main public hospitals. And then there's private hospitals, NGO hospitals, and mission hospitals as another assessment. Another key difference too is with this Ethiopian adaptation, we're able to look at the workforce in terms of all the different levels of surgical and anesthesia providers in the country. So as you all know, in other countries, a lot of times the people providing surgery aren't necessarily surgeons who are MD surgeons, have gone to residency, et cetera. There's other people providing surgery. So this allowed us to capture how many of those people were also working at these facilities. So for Ethiopia specifically, that's the integrated emergency surgical officers who go through a shorter training to be able to provide certain emergency surgical care. There's also general practitioners who have completed medical school and are then kind of stationed in usually rural areas or areas of need to provide some basic surgical care as well. There's also a lot of different levels of anesthesia providers. So as you can see, there's about 5 different levels of anesthesia providers in Ethiopia. And so this allowed us to quantify exactly those different levels for each facility. These are busy slides, but kind of giving, I'm going to go through these a little bit quickly, but to give kind of a overview of the readiness assessment. So what we did is essentially we did the SALTS tool and its completeness at these 14 facilities. And then on the back end, we looked at if we analyzed this using the SARA modifications. So the SARA, is a service readiness assessment from the WHO, which has international metrics that should be comparable. Can we use this tool to then look at also a readiness score that could be internationally comparable for each of these facilities? And our tool had all of these indicators except two. And so we were able to quantify this kind of readiness assessment as well for these facilities. So this shows kind of general infrastructure assessment for each of these facilities. And so those ranges of numbers, that's the percent of time available. So for instance, for the primary care hospital number 1, running water is available 100% of the time. Electricity is 26 to 50% of the time, which was pretty common for most facilities. Didn't have electricity 100% of the time until you went to a general or specialized hospital. And so this is using the actual SARA metrics to do basic surgery readiness. So this shows you the kind of equipment and medicines that are needed in terms of those metrics to look at what is required to provide basic surgery. And so we were able to give kind of a mean readiness score for the hospitals there based on that assessment. This shows you the comprehensive surgery readiness. And so this shows for kind of the next level of surgical care. And a lot of this goes more into intubation and anesthesia resources as well. This shows you what the readiness score was for those facilities that were expected to provide comprehensive surgery. And so this is the procedures itself. So another key difference with the development of this assessment tool is the Ethiopian Ministry of Health had different goals for different levels of hospitals in the nation. So for instance, at the primary hospital level, it was understood that they should be able to provide a certain set of surgical procedures there. For the general, it was those procedures plus a few more. For specialized, those procedures plus a few more as well. And so we were able to look at exactly those set of surgical procedures that are supposed to happen at each hospital level and whether they were able to provide those surgeries at each of these facilities. Comparing that to the SARA tool, so of course there's a different kind of level of facilities and what is expected in terms of the procedures that are supposed to be provided at each level. So this gives a little bit more detail into that of the basic surgery readiness and comprehensive surgery readiness in terms of the procedures and a couple key differences there. So this shows a comparison between those different procedure availabilities. So, you know, the goal for this Ethiopia-specific surgical assessment tool is to be able to assess those facilities in terms of being able to provide the surgeries expected at the national level. And so you can see the green lines are related to SALT or the Ethiopian policy and whether the procedures expected to be provided at each level are provided there. And then as a comparison, the SARA tool as the procedures that I showed on the previous slide shows whether those procedures were provided at each of those hospital levels. Okay, so that was a quick whirlwind of everything, but some important lessons learned in this study. So context is important. So I think one of the key things here was that developing this tool and adapting it for Ethiopia specifically, it allowed us to really get granular detail about the hospital system and to make that congruent with the policy going forward in Ethiopia about the expectations for surgery in the country. As I pointed out, you could get a lot more granular detail about the number and the level of anesthesia and surgery providers in the country. Some of the drawbacks of this. So as I talked about with those 363 questions, so it is a time-intensive study to do. The cost of going to these facilities, having the big team able to do this and doing the analysis on the other end definitely takes time, takes money. And so there's we were fortunate to have GE Foundation grant funding to kind of get this off the ground. But in terms of going forward and being able to continue to do these assessments on 2 to 5 year basis requires some further infrastructure and thought. And then a couple of my own kind of thoughts as well. So some future directions in Ethiopia, just to keep you all updated. So there's been kind of SALTS 1 has closed 2015 to 2020 and SALTS 2 has now started. So they're updating the goals for surgery in the country using some of the same tools and KPIs to see what's going on currently and to make plans for the future. So future directions globally. So as Dr. Kalolo stated as well, there's many different ways to assess surgical systems and surgical readiness. So we talked a little bit about Sarah. He had mentioned the SPA as well. And now there's from the WHO, the Harmonized Health Facility Assessment. So what, kind of the provider on the ground perspective is that all these different institutions or different groups kind of come in with their different assessments, and a lot of them have a lot of overlap. So the goal with this Harmonized Health Facility Assessment was to take away some of that overlap so that there was more of a kind of global assessment of facilities that would address a lot of the same questions and concerns from all of these different outside groups. And then some of my current work in Ethiopia. So I'm focusing more on those key performance indicators, as was mentioned previously, and the integration of this into regular data collection and how we can make sustainable, better monthly data collection in Ethiopia. So I'm happy to collaborate further on that or answer any questions about that as well. So this kind of gives you, as I mentioned, some of those different tools for surgical assessment. So we used the SARA tool there, mentioned the SPA tool, which comes from USAID, and then the Harmonized Health Facility Assessment is kind of the newest and greatest. So I appreciate having the time to talk today about something that I really love, and I am always happy to collaborate, hear more opinions, hear further questions. So don't hesitate to email me. I also put that in the chat as well, and hopefully we're about ready for questions. Thanks.
Thank you so much, Dr. Iverson. That was a really fantastic presentation. We again really appreciate your time, and good to see you again here at PGSSC. So I wanted to again say a big thank you to both Dr. Iverson and Dr. Albino for two really informative and engaging presentations. It's clear that both studies have contributed pretty significantly to understanding of surgical readiness in Ethiopia and Tanzania, and also have the potential to be more broadly applicable or translated into other surgical readiness assessments, which is something that this group is very interested in. I think, as mentioned before, now we'll open up the floor to some questions and discussion. We have about 30 minutes left. If anybody would like to ask a question, we're going to encourage you to raise your hand virtually, and hopefully I'll catch you that way, or you can pose a question in the chat. And while folks are kind of gathering thoughts and getting ready for that, I will start off with a question for both Dr. Iverson and Dr. Kalolo today. So Dr. Iverson, your presentation mentioned and discussed in depth your adaptation of the SAT to evaluate infrastructure, human resources, supplies, surgical service delivery. And Dr. Albino, you primarily focused on evaluation of infrastructure. I guess my question for both of you, and you can take it in whatever order you'd like, would be to what extent should baseline assessments or pre-intervention assessments of surgical systems include additional metrics? For example, data on patient perceptions and outcomes, qualitative data from healthcare staff at the facilities you're evaluating, and what are some of the pros and cons of adding these additional metrics in a pre-intervention assessment? And Dr. Kalolo, why don't we go ahead and start with you?
Okay, thank you very much for that question. As I already explained that for us, we didn't include the patient outcomes data. And yeah, I think it would be interesting even during the baseline to know what is the situation at baseline so that at the end, we could also check whether the investment that has happened over years, whether there is any impact when it comes to patient outcomes. Yeah, so it's a data that I think is worth correcting. Yeah, but of course, probably will not see the patient outcomes in a shorter period. So probably the period could be even longer so that you can get the real picture, whether there are any changes after all this, the investments in the, in the healthcare system. Thank you.
Thanks, Sarah. That's a great question. So I always say, and I'm always telling my research team that we don't know where we're going if we don't know where we're starting from. So I am a big proponent of baseline knowledge in some form. So I think my goal is partly with the Ethiopian KPIs too, or the key performance indicators, is to find a way to get more regular, sustainable surgical data, which I think is kind of where we're at now. So, previously a lot of people were doing these health facility assessments, and I think, we still are, and there's still a lot of value to those. But also we need to figure out a way that we can create a system where we can get some adequate baseline data about surgery, about surgical outcomes. And then once we're implementing strategies to improve surgical system and surgical access, to be able to monitor the results of those. So I think what I've kind of also imagined too, and this is just a thought that's not, maybe fully developed, but if there's a way you can create kind of like almost like the NISQIP Lite, for surgical systems, is there like a hospital assessment tool Lite or surgical outcomes Lite that we could use some basket of metrics that we can say, this actually assesses a facility well in these like 10 indicators and gives us reasonable amount of data. And if that can be used to guide some of the implementation for projects in the future, there's a difference between, I think, these projects for increasing surgical capacity, but then also on the ministry level or on the national level, needing to know exactly like what's going on the ground in that really granular data.
Thank you both for those responses. And I certainly have some follow-up questions, but I do want to open up the floor to others who might be waiting. I see that 641 has your hand raised, so I'll turn it over to you all. (641) we cannot hear you.
Anita, your microphone's not on.
While they're figuring out audio. Oh, there you go.
Okay,
go ahead.
Okay, you get okay.
Can you hear us now? Okay, awesome. I'm Benita. I'm a medical student from Chicago and one of the researchers here at PGSSC this year. Thank you both for these awesome presentations. They were very enlightening and super interesting. Dr. Iverson, you kind of led into my question really well, I think. I'm wondering, when you think about next steps and being able to implement this kind of on a continuous basis and do regular evaluation of the systems, for both of you, how do you really see this being done, especially Dr. Kalolo, like a lot of the paper you mentioned, they consolidated a lot of resources from various different implementation reports. Like, how do you see this being implemented on a regular basis and being able to do this evaluation with ease?
Dr. Kalolo, do you want to start? And then I'll finish.
Yes, but I doubt whether I understood well the question. I don't know if someone can paraphrase so that I get exactly.
Yeah, I guess I'm interpreting it, and correct me if I'm wrong, Benita, but the sustainability of doing these health facility assessments and what would be a good strategy going forward. Does that sound fair? Yeah, okay.
Okay. So you mean the doing it routinely?
Mm-hmm.
Okay. Yeah, I think it's possible to actually do some routine data correction, but in some countries like Tanzania, where resources are very limited, sometimes routine assessments cannot be feasible. but it's something worth investing probably for the future. But currently, it's something that is very difficult to actually correct all this data routinely, because most of the, health facilities are not well developed to the way that they can correct routine data, even though, yes, there is like some intervention to digitalize data correction. So if the digitalization process happens, it will be easier to correct real-time data, and then things can work well. But currently, it looks like routine data correction is nearly to impossible, especially in our settings. Thank you.
Yeah, I would say in Ethiopia, they did do another big health facility assessment at the end of SALT. So for that like 2020 assessment, 5 years after the national policy was initiated, and actually did health facility assessments at all of the public hospitals in the country. And so I think there's support from the ministry for that. So that's where a lot of the funding and support came from for that. So I think that it's practical to do some of that, especially once you have a big network of providers in the country, maybe on like a 5-year basis or so, to kind of see the status of what's going on. But again, I think the next step too is getting those surgical indicators and the quality of surgical data on a regular basis, kind of like Dr. Kalolo is saying. That part's still difficult to kind of figure out the best way to collect some of those metrics going forward, I think, and definitely changes with each context, but definitely requires a lot of support, I think, either from outside groups, especially for kind of startup in Ethiopia. That was really instrumental for the startup of the policy, but then having ownership transition to the Ministry of Health or other kind of health groups within the country as possible.
Thank you both. I'll turn it over next to Dr. Gauthier.
Thank you. And thank you both for just excellent research papers and summaries here for the group. I'm very interested in issues related to data quality, in both data quality in terms of your prospective data collection, in terms of completeness or accuracy, but also you've talked about some secondary sources that you might be able to look to in terms of patient volume and patient outcomes and the quality of those. And so my question for both of you is issues that you might have faced related to data quality in your own studies, and how that how you mitigated that, or how it might affect your results, but also to help us think about if we were to replicate this in other countries, what recommendations do you have for us to make sure that we do have good quality data in our efforts?
It's a complex question. But yeah, that's a good one. That's all of my current research is about data quality right now. So I definitely feel the pains, but I think one of the things, I guess I'll comment on two different parts of that. So for the hospital assessment tools, so what we did after the pilot study and some adaptations from that was then do some regional and national trainings for people who would be carrying that forward about how we expected the tool to be done, kind of some different nuances about it. So I think that was helpful for that part to kind of get everyone on board. But of course, then there's turnover, right, which is pretty frequent. And so the people that we trained, 5 years ago, I don't think are the same people who are doing those assessments now. So something to consider for that. And then I think in terms of data quality for more of like the regular indicators, that's where my current work is lying, and something that we've gone back to facility. So looking specifically, I'll just say, for example, like at surgical volume and some perioperative outcomes like perioperative mortality rate or surgical site infections. So again, I think there's part of the issue is with reporting and what is done with that data. So sometimes there's some disincentives to report the accuracy of that data based on what kind of feedback facilities or specific providers get. So that's something that's more on the system level. And then in terms of getting reasonable metrics for people after they leave the hospital is kind of a whole nother system. And so right now, in Ethiopia, we focused on just inpatient data and making sure that we have a good system for getting that adequate inpatient surgical data. But I think actually capturing the full scope of perioperative practice, of course, requires a system to be able to track the outpatient data as well. So I guess I don't have good answers, but more questions. But I think, it's an area that definitely warrants some further investigation.
It's Shanaz here. If I can just add, something we did in Tanzania was to have an administrative manual where we defined very clearly each indicator. And so when we were doing a pre and post assessment, we knew if we were comparing apples to apples. We also did training of our data collectors just before they started the data collection. And then we had data quality checks, both like our research assistants checking the data, but also running electronic checks to catch any errors. So I think that helped a little bit, I felt.
Yeah, that's a really good point. So in Ethiopia, there was, kind of a playbook that we called it a playbook created for each of these monitoring and evaluation strategies. And so that kind of specified really in detail. I think the one for the hospital assessment tool is like 50 pages or something about like each of the questions and how it should be interpreted, et cetera. So that's a good point, Shanaz. I think having some extra tools and extra kind of printed material about what's expected for that can help with some of that staff turnover as well.
Thanks so much, Dr. Iverson. Dr. Kalolo, I don't know if you want to make a comment on that question as well. I'd be very curious, given that your study used a variety of different data sources, kind of how you approached data quality concerns as well.
Hello. In fact, I missed the question because of the internet interruption. So Shanaz has somehow responded. Now I don't know where to chip in, and yeah, I don't know if there is anything specific where you think I can chip in because I had missed the question.
Dr. Gauthier, do you have any additional?
Yeah, so the question was related to data quality and how you addressed issues related to data quality in the study you presented, or any advice you have for us if we were to do this again in the future related to data quality. So I don't know if you heard Shanaz's response and want to add to that.
Mm-hmm. Okay, thank you. Yeah, when it comes to data quality, yeah, so as I said that we use the data that has already been collected from this, like the SALA, the various reports that have been sent. Yeah, so we had to check the completeness. Data which were not complete, for example, we didn't include them in our analysis. And whenever we had a doubt, sometimes we also did some phone calls just to verify some of the data. Yeah, so the data that was included in the analysis, we had all these checks so that the various conclusions that we reach are somehow, trustworthy if you compare, if we could not have did some checks. But always the routine data or the data that is collected for other purposes might not be complete to actually answer all your research questions accurate. So we had to drop some data before analysis. Thank you.
Thank you both for answering that question. And I know that data quality and management of types of data like this is incredibly difficult, and we very much appreciate hearing your perspective on that. I think next we'll turn it over to Louisa, who's had her hand raised for a little bit. Louisa?
Hi. Thank you both so much for your wonderful talks, Dr. Iverson and Dr. Kalolo. I had kind of 3 questions, but I'll make them really brief. I have just come back from collecting some data at home in Botswana regarding like spine surgeries and hospital preparedness for performing spine surgeries there. And one of the questions I had was, nowadays we're moving towards more of an EHR type data collection system. And I was wondering if you thought that there is a role for using phone-based applications instead of just like an electronic internet-based method. My second question is, many times things like spine surgery, they're really, really specialized. So you have only a few people doing these surgeries. And I was wondering if you could speak a little bit about any issues that we might encounter with clustering, because all these things are based off of usually one person's point of view, one person's experience as the surgeon in that country. And then my third question, sorry to ask so many, is for me, it seems as though there is no standard data collection tool for spine surgery, similar to what you guys had for from the WHO for general surgery. I was wondering if you could talk about developing your own tool in that way and some of your thoughts associated with that.
Okay, can I go ahead?
Yeah, go for it.
Okay, thank you. Yeah, so maybe I start with the first question. Like what I said previously, that in Tanzania, still the routine data, for example, we are not completely using the digitalized system. Still, we have some paper-based way of correcting routine data. But if there is like an assessment, the periodic assessment, that is where the questionnaire and whatever can be digitalized so that it simplifies data correction. And for the data that we analyzed, which were mainly for the primary health care, most of the data were not corrected using digital tools. So it was from the papers, and then later on maybe synthesized, and then you get the aggregated data. Yeah, so that is the situation of the data that we analyzed. But regarding your question on spinal surgeries, as you know, spinal surgeries are done in specialized hospitals, especially here in Tanzania. We have very few neurosurgeons who can actually do specialized, neurosurgeries. So even the way, the way this data are collected, the systems have not been well developed. Even the various indicators you would like maybe to be reported probably are not included in the routine data correction. Maybe with the time, such indicators will be integrated because there is a push now towards improving surgical services from the basic surgeries to specialized surgeries. But in our study, for us, we focused much on primary health care, and we had a bias on maternal and child health services. So we had the CMOC, comprehensive obstetric care. So that was our main focus. And I don't remember well the last question. I don't know.
Any concern about clustering, because there are not a lot of surgeons doing it, so not having really, really good data quality, because then your sample size is very small.
Yeah, for us, I think our sample size was large because it was a country wide data where we collected from several health facilities and actually pulling data since 2005 to 2019. So it's actually many years, even though, yes, we had to drop some data because of the poor quality. Some were not complete and things like that, but still our sample size was relatively large to actually, I mean, we are confident for what we found is somehow representative for the country. Thank you.
Thank you.
So I'll maybe make just a couple comments to leave space for another question, but I think, yeah, like you said, so EMR, I don't have as much experience with that in Ethiopia. Not many facilities have EMR, and so we're relying on paper registries, but I do think phone follow-up has been shown in a lot of studies in a lot of ways to be really effective, especially for postoperative indicators and for like complication tracking, things like that. I think that's really useful. I'd be less worried, I guess, about your sample size being so low. You know, obviously you're not trying to like power the study to kind of show, you know, a difference between providers, but just to get some like baseline statistics and like descriptive statistics, I think it's great to be able to get a starting point. And then what was I going to say? I think so for, you know, the Ethiopian tool that we created, there's certain metrics that are specific for specialized hospitals or those like tertiary care centers that have what kind of tools you would want there and what kind of procedures are available. And so I think within some of the hospital assessment tools, there will be kind of like a segment of that that's going to be specific for that specialized surgical care. And so that might be a good place to start for that. Yeah, I guess I'll pause there for now.
Thank you.
All right, and we probably have time for just about one or maybe two more questions. I saw that Maureen and Rohini had their hands raised at one point, but I'm not sure if they're still there. Okay, great. I'll turn it over to you both.
Hi, my question was actually for Dr. Iverson. When we were going through the paper, we realized that you got a lot of questions. I mean, you faced a lot of political barriers and you were only allowed to do the research in a specific region in Ethiopia in only the 14 regional referral hospitals, and it was through in-depth interviews. And I know today's Q&A has been a lot about data quality, but I was wondering how in the future, another team could maybe do a similar type of research, maybe in Ethiopia, maybe in other LMICs, and how they can overcome those barriers to actually access direct audit forms that the hospitals might be keeping, so we could get a more accurate idea of the surgical volume and the inventory that is being kept.
It's a really good question. So yeah, a lot of this, as you alluded to, is related to some political kind of strategy, I guess is the way to say it. But definitely we had to get kind of approval for different regions that we were working in, and even the facilities were essentially kind of picked out by the regional health bureau or the people who kind of were in charge of the SALT strategy. And so, you know, we didn't have a sampling strategy that was more depictive of, you know, a general kind of national strategy. And so, or a nationally like representative data selection. So that's definitely one of the limitations of the study that we did and of, you know, the other studies that I've been involved with in Ethiopia. There is though the most recent publications that came out from the SALTS group back in actually like just the past year or two, were able to survey a wide range of facilities. So I think it's a difference probably between outsiders coming in versus having an internal group do the hospital assessment tool. And so I think the SALTS team has been able to do more of a nationally representative study of a lot of the surgical capacity of facilities. And so that's definitely, yeah, something that could be improved upon in the future for sure.
Thank you. I appreciate it.
And I think with that, given the time, we'll stop questions there for now. I know that folks have additional questions for you, and we really enjoyed discussing both of these papers on Tuesday at our journal club. but we'll let folks reach out with additional questions if they have them. Again, a huge thank you to both the presenters. I really want to just share this Menti poll as well to demonstrate where our group is calling in from today. We have a pretty wide representation, so it's really great to be able to hear about this type of surgical readiness assessment work that you're both doing from kind of a broad variety of perspectives, and we all really enjoyed and appreciated your time. For the next time, we will have our next PGSSC research seminar on Thursday, April 13th. Again, you can find the registration for that on the website, and we will be sending out some additional reminders. But overall, thank you both to Dr. Iverson and Dr. Albino for two fantastic presentations.
Thank you for having us, and yeah, feel free, definitely don't hesitate to reach out. I'm serious if you want to talk about surgical data, data quality, etc.
Thank you too. It was nice participating in this presentation.